So this is a 76-year-old male presented with the shortness of breath. He has history of hypertension, dyslipidemia, PCI 10 years ago. He then received a surgical aortic valve replacement 7 years ago. He suffered from endocarditis, and also he received a pacemaker implantation 2 or 3 years ago. The echo Doppler showed atrium dilatation with some hypertrophic, and also a bioprosthetic aortic valve with severe dysfunction, also with severe aortic regurgitation, which in my opinion is the main issue in this valve. So this is the angio. The stent, which is in the proximal part of the LAD, is okay, no restenosis. You can observe a big right coronary artery with some calcification on the sinus and the sinotubular junction. So there, in this cranial angulation, it's better observe this very small ostium of this right coronary artery. And here on the angiography, we can observe a severe aortic regurgitation on this valve, probably a damage because of this previous endocarditis. According to the app valve, we can use a balloon or self-expandable valve. We have chosen a balloon. We are going to predilate with 22 because it's a patient with the severe regurgitation, and we had to place a stent on the right coronary ostium. So this is the CT scan. Inner diameter of the valve is 21. The ostium's heights are for the right 17 and for the left 18. The calcification at the level of the right coronary sinus. So this is the right iliac artery, which is a good artery, big, without significant calcification. This is our axis. This is the left, which is also, again, a normal artery. And this is the aortic configuration. There is not significant angulation. So in summary, it's a 76-year-old male with severe aortic bioprosthetic dysfunction. We have decided to treat PCI to the right coronary ostium and TAVI implantation for this bioprosthetic failure. So this is our strategy. Dr. Fava has prepared a radial access here, a 6 French left arm. We have contralateral access for protection and to introduce the pigtail. We have a 6 French that we have already done. So we are going to introduce one proglide and one angioceal in this case. So now we have introduced the sheath for homolateral access. We are going to introduce the right coronary artery guiding. Wait. Let me go distally. Oh, probably I made a big curve, too much big. I think I am distally enough here. Okay, so now that I have the wire, as you can observe, there is a significant calcification on the aortic wall. So my intention was to predilate with a cutting balloon. So probably I will try to cross the valve before. Then we predilate the right coronary artery. We can check the positioning for deployment of the valve just in case we have to rush. Bring another stent. 15 is too short. Or 18. Give me the pigtail. Let's move. Cutting 2.5. So let me cross the valve. It's not that easy when it's a prosthetic surgical valve. Oblicua derecha.
Cutting.
Okay. We have extrasystoles. We have, no, wait a minute. Let me position in the pigtail a little bit better. On the apex. Okay. So the ventricle is huge. But this is a very special case because we had to take care of the ostiums. So I thought it was better to use this technique to do all together. So we only have one injector. Perfect. We have a very orthogonal view of the surgical ring of the valve. So we should go first to the to predilate the right with the cutting. I will introduce an extra bend to the wire. Vamos a la oblicua izquierda que estábamos. Now give me the llave de 3 vías. So we'll connect the injector here on the, give me this. This is the cutting 2.5. So we will try to predilate the ostium with this. If we have a good dilatation, it's gonna be okay. I will try to post dilate as much as I can. This is an obese patient. Here we are, in the middle of the balloon, inflate. 1, 2, 3, 4, 5, 6, 7, 8, 10. So it looks too small, deflate. Let me check. Okay, everything is okay. Let's go with it 3.0. And then I think we can deploy a 3.5 by 15, the stand. Okay, as you can see, the guiding, all the guide, and also the telescope. Let's go 10. It seems better. Okay, deflate. Let me pull and push, trying to rotate the blades. So maybe we can have another ablation in a different place of this calcium. Let's go again. 14 atmospheres. Okay, everything is okay. Give me some small amount of nitro because we have some spasm there. Okay, I will use probably 100 or 200 micrograms. Let's pull the balloon out. Give me the 3.5 by 18. While this 10 is there, I'm going to advance. We haven't prepared for rapid pacing. We are going to do it with the wire. I have to put the big needle here, here on the skin. More things than usual for a TAVI case. Okay, give me the stent. I am introducing the stent. The stent is going to be near the ostium of the catheter. Let me see. Okay, it's inside. Perfect. And now the catheter is inside the gut extension near the ostium. I will advance everything together. It's advancing okay. Let me go with the wire. High pressure inflation, the indeflator. I'm putting the wire there. Valve is ready. So we can proceed with the balloon. So show me the annulus. We are going. Scratch the wire. 180. Ahora, infla. Fuerte, rápido. Rápido. Desinfla. 180. Sí. Rápido. Okay, now Carlitos, inflate. Very fast, very fast. Okay, 10, 12. It's okay. Aspirate. Para el marcapaso. Okay. Now we have to recover the patient. Carlitos, pull this, everything out. Aspira, Juan. Bolos. Coto. Dale un bolo. Otro. Otro bolo plus. Balloon is broken. Mostrame abajo. Okay, arriba. Wait. Push the wire. Hacele otro centímetro, por favor, de adrenalina. Dámelo aquí. Dame adrenalina aquí. Dale, agarra la adrenalina, Juan. Vos agarra la válvula.
Dame la válvula.
So I'm going to introduce everything here. I'm going to go with the valve as soon as I can. I'm going to bolus of adrenaline. It should be ready. La punta de la guía y el introductor. Aquí. Dalo. Tené, Carlitos, la guía un segundo.
Dale.
Okay. So I'm going to open. Empujame la guía. Mostrame el balón. Más abajo, más abajo. Ahí, ok. Okay. And now we have to hold it here.
No.
We have to introduce the balloon.
Tiene que
Okay, we
montar.
are ready. Let's go. Vamos arriba. Anda a la procesión de trabajo de la válvula. Dale una adrenalina acá en el venoso vos. Bueno, rotate. Por ahí vete. So here we are in the position. The patient is too hypotensive. It's not necessary. Pone más caudal. Yes. Sí. Now let me see. Now the valve is working. Let me show in oblique izquierda. We'll put the stent. Dale otra adrenalina. Okay, inflate. 10, 18. Okay.
18.
20. Desinflar. So, sí.
Guarda eso.
Okay, I think we have to compress. Vamos a sacar esto. Vamos a marcapasear y we have masajear. We have to compress.
80.
Okay.
80, 100.
Give me another adrenaline. Delivery system is out. A 100, ponelo a 100. So we have to work on that. Ostium is okay. Let me check. Okay, unexpected situation. No pericardial effusion. So I think it's feed related. No, no. Compress, please. A very sick patient. You know, we have to keep doing that. RCP. A ver, déjame ver. I think the patient is now recovering. Okay. A very tough situation. Be careful about the arrhythmias, so on. Now we are okay. Sorry about that. Let's check the stand. More pressure, please, there. Let's do 0 in the pressure. No, give me a nitro because no, el 0 is okay. So let's check the ostium first. I don't have a good positioning with the guiding. Now I think it's better, in fact. So the stand is perfect. The patient is doing much better now. So I'm gonna pull the balloon just in case I have to post dilate. I will use a high pressure balloon. So you can show the hemodynamic. The patient now is a little bit hypertensive. Let me do some nitro here in the coronary ostium. Okay, let me go to the coronaries. Give me some additional nitro. Give me the Amplatz wire. I will pull the catheter out. Maria Eugenia, regurgitation doesn't seem too much because the systolic is the diastolic pressure is 120. Have some hematoma here. Okay, and what about the gradient? Oh, that's more than okay. Okay, we might wait some minutes to recover a more normal hemodynamics. So the valve is circular. Okay, great. So let's do an angio now. 15 by 20, probably here, about the stand. Let's check. I think the position is probably a little bit deeper than I would like to do it, but you know, I was in a rush. In fact, no regurgitation at all. So we have some hematoma here. You can compress from the other side. We are not going to post dilate anymore. Call the introducer, Carlitos. So we are going to put the pigtail and measure the gradient. The ostial stent is perfect, and I think the valve is more than acceptable. Now we will have to deal with this hematoma. We are going to use a closure device on the left side. Here, you can share again, Rich, the hemodynamic. I think they are really beautiful. No gradient at all. Diastolic is perfect. I think our outcome here is reached. So I can pull the catheter out from the ventricle. So let's see. Leave the wire in, Carlos. We are to do a final test on the right coronary ostium. Let me check. Ok, mostrarme mejor el ostium ahora. Dime un balón de 3.5 de alta presión. I'm going to post-dilate this ostium, although I did a atherectomy, still a little bit compressed according to the angiography. I would really like to post-dilate to prevent any restenosis. We will take care of the ostium. Let's go slowly, but to high pressure, to 20, 22, 24. It's 3.5, 28. Okay, that's okay. The guiding proximal. Okay, in fact, well, the guiding is not perfectly engaged, but I don't like to distortion of the stent with the guiding, which is prolapsing. Now I think it's much better. We have used 3.5, a very high pressure. We have had many problems, so I think we are done with this. So give me a balloon, an 8mm balloon, access site before, and then we are going to close with an angioseal. Give me the introducer, Carlos.
Cut.
Sí, cortalo. Okay, the blood pressure is okay. Carlos is gonna hold the groin while I cross over with the balloon. Going to contralateral is not that easy. Probably it's too bulky, this balloon. Give me a different balloon. Let's see. If not, give me the mammary catheter. Okay, now it's okay. Now it's okay. Okay, I'm gonna need a 6 French. Okay, hold in here, Carlos. Okay. Give me an 8 French angiosyl. So we are more than happy that we recovered the patient. It was a really tough case. So now, I think we're okay. So let me check how is the ceiling on the groin. Carlos, let me see. Abajo. Más abajo. Okay. The ceiling on the groin is perfect. So now we are holding because we have a oozing on the skin. We are going to check now here, the homolateral side, pull the wire out. I think it's okay. Let me check here if we have bleeding outside the sheath or what is going on here. Mostrame la ingle. La otra.
La otra.
Okay, there. Yeah, so we have there. So let's put an 8 French angiosyl. And then we are going to compress and probably we have exactly stick where this branch is. Okay. So this was the reason of why we have some bleeding there. Okay. Give me the angiosyl. It's here. Anyway, we are going to compress. We have a problem. Unfortunately, there was a kink in there. Probably this was the reason. And I destroyed the angiosyl. Let me see if I can introduce the wire. Give me another 8 French angiosyl. Give me the unplus wire again, or the sheet. Okay. There is a kink there. And this was my problem. And this was the reason why. Mostrame arriba. I couldn't introduce completely. So now I'm going to leave. So there's a problem with the angiosyl. Comprime, Carlos, mucho. Sí. Give me this. Anyway, it's not going to be enough, but it's going to help. As you can observe, the hematoma is there, but we don't have bleeding. So this is good. Okay, corta. Okay, leave it there. So Dr. Fava is going to hold with Juan the groins for probably 20 minutes to be sure that everything is okay. So we're exactly on time. We really passed a very tough situation, but fortunately we reached a very nice outcome, not only on the right coronary ostium, but also on the TAVI case, in this case for this valve valve with the previous cracking. The patient collapses after the cracking, but there was no mechanical complication and everything is okay. So probably now we need a better medical management. Probably it's a patient with not enough preload. So we might check by echo if we need to expand him a little better because the blood pressure is okay, but the diastolic pressure now is not that high. So once again, I would like to say bye and see you next week. Thank you so much for helping us.